So let me go in slide mode. There we go. So, thanks for that introduction. I think some of you guys are familiar with this work and may have heard this version of this talk before, but others, I am excited to share our work here. I think I'm some requirements here to show these accreditation slides. Okay, so let's get us grounded a little bit. I'm going to talk about artificial intelligence, which is a pretty big field. There's many subcategories within artificial intelligence. So it's kind of a little schematic. I kind of get you grounded a little bit. Like there's all types of machine learning within AI, and then machine learning can have really, big models that go into what's called deep learning. And now with, what you guys have heard of as ChatGPT comes from a world called natural language processing, which is learning how to work with words and linguistics. And you guys, as we know, there's now AI tools that radiologists are using with images. So the technology I'm going to show you is what we developed that kind of crosses the worlds of kind of the ChatGPT kind of stuff with kind of deep learning stuff. And this is kind of we developed this software actually, it predates it was kind of in the middle of all this emergence of ChatGPT and things like that. So a lot of similar technology there. Now, the bigger issue is that it's great that we have all these AI tools, and it's changing our lives. I do believe it's going to look, our workforce is changing as we speak. But that being said, these AI technologies are not developed in the healthcare space. They come from general domain stuff. So unlike pharmaceuticals, where like we have drugs that are developed in healthcare, regulated by FDA, we go through clinical trials, that type of kind of standardization and regulation is less so in the AI world. And so we're bringing technologies that are developed outside of healthcare and applying them in healthcare. So you can imagine the fit for purpose on these things is way off in a lot of cases. So I would argue that even though the tech looks great and it's got a lot of bells and whistles to it, there's still a lot of issues in how we implement them and systems engineering and kind of like where does this kind of fit into our workflows or even redesign our workflows. And so this leaky pipe is kind of the picture to kind of say, look, even if you look at during COVID era, like there were like 300 prediction models published for COVID variants things, and less than 1% actually go into practice, and even less so have an impact. And so we still need clinical trials, we still need implementation science. And what I'm going to describe of this technology is kind of putting into what's called clinical decision support, which is all these nudges you guys may get from the electronic health record or in your clinical care workflows. And so really there's these five rights that we need to align with the technology. One is getting the right information to the right person in the right format and the right channel at the right time. We did well in some of these things, but I even think in this use case I'm going to show you we still could do better in others. So the problem that we're addressing is screening for opioid misuse. The USPSTF, the United States Preventive Task Force Services, recommends this. We don't technically have a formal screening program at University of Wisconsin for hospitalized adult patients, which is what we're focusing on here. Although we do ask the question of drug use, but it's kind of just a question that's part of intake and nothing's really acted on it. Regardless of that, the number of substance use related hospitalizations are continuing to grow. People coming in for wound infection, sepsis, endocarditis, asthma, with some underlying substance use disorders sometimes associated with that. And we have an amazing addiction consultation team in the services here with Dr. Egan and folks on this call. But as you guys know, you guys receive consultations based on the provider's discretion, and sometimes there's delays in when you get consulted, and we're not really even tracking the epidemiology of the screening that may be done by the providers ad hoc. So this software I'm going to walk through is kind of developed to validate to be a screening tool that's AI driven and show how did this play out in practice. So we are trying to leverage data that's already being collected. We're not trying to bring in new kind of works patterns or routines. It's kind of like, okay, we have the inpatient setting, and 80% of the data collected in this setting is in the notes format, the notes that you guys are taking and intake notes and progress notes. And when we looked at it, like over 97% of these notes have some mention about substance use, whether there is any or there isn't any. Our social history sections, right? We're trained to ask these questions. So you can imagine the power of the information, but it's hard to kind of sort through all these notes and make them actionable. And so that's what this technology is intended to do. Plus, manual screening programs that are human-led, you get a screener that comes in, the patient's never known before, may not trust, a little different than the doctor or clinician-patient relationship, so the rapport may not be there and we know that patients underreport a lot of times on some of these screening questions. So in these clinical documents in the EHR and electronic health record, there are many different types, right? And so this is a list of all the different types of notes that are being captured. And you could imagine, like I mentioned earlier, in history of present illness or in the social history section, there's these, documentation of explicit mentions of substance use or other things that are kind of less explicit, maybe risk factors associated with substance use. So a little background into our technology here is that we take all those notes in the raw text, and there's different ways to say the same thing. And the National Library of Medicine at the federal government level actually has a whole set of dictionaries of medical vocabulary, and they actually did all this work to standardize it into these concept IDs. And so this is one example from their website, which is they have a whole thesaurus of all the possible terms where opioid misuse gets tagged to this ID, and there's other related tags like unhealthy opioid use and other things that go with it as well. So we may say things differently in the text, but they all get mapped to the same medical concept. And that's what we're leveraging in this technology to kind of get a common data model approach so there's less variance between sites and practitioners. And so when we do that, we kind of simplify the workflow for the AI model. We kind of take all the notes and just combine them all together. We process them through kind of a software that we worked with that can do all this mapping to these medical concepts, and out comes this one file that has all these codes in it. So just kind of an idea of what's going into the model. Now we had to then build the model and train it and have it learn how to behave like a human screener. And so we went to a health system in Chicago, Rush University, actually in Chicago, who at the time their substance use intervention team was actually manually screening everyone coming in through the hospital. It was a huge kind of undertaking, and they were running audits and DASTs on everyone. And it wasn't recorded in the EHR, it was actually collected outside the EHR, and then like the flags were presented in the EHR. So it wasn't like it was part of the notes in themselves. So we took that as an opportunity to try and train a model to kind of learn the way these screeners were learning, which is that, but using the notes. So we had all the kind of screen positive and screen negatives off the audits and DASTs. And then we kind of fed that as kind of the target using the notes that were being documented as part of usual care. Can it learn to make those predictions of screen positives and screen negatives the way the manual screeners were identifying these cases? And so this is kind of showing a diagram. It was actually done in over 80,000 patients over a course of several years. And there were, thousands of patients that were identified. So this is really, in some ways, high quality training data that even ChatGPTs and other models don't have access to. The other thing we did was we focused on the first 24 hours of a hospital stay because we wanted to give the addiction medicine team and addiction providers enough time to, see the patient and do an intervention and do what matters after the screening happens. So again, a little insight into the technology here. This is kind of the workflow that we follow where, like I mentioned, we have all these concept codes, and then we have the audit and DAS results, and we're taking the concept codes and kind of doing this machine learning to kind of learn, can it identify from those audits and DAS which ones are positives and negatives. And we do this and train it, and then we test it. And the software actually puts out 3 predictions. It'll give you yes, no for opioid misuse, yes, no for alcohol misuse, and yes, no for non-opioid misuse. And you can turn on and off any of these that you wanted. So at UW, we actually only turned on the opioid misuse because you guys already had a alcohol screening program as part of your trauma center, and governance folks didn't want to compete with that. And non-opioid use misuse, we didn't turn that on because you guys told us like, you're still figuring out how to treat those conditions. So you have the raw text, you have all these random words in those texts, and these are some examples. Those get coded and they get fed into this AI model. In our case, what we did is we trained something called a neural network, which is a very fancy, kind of complicated set of models that look at all the possible combinations of words and concepts and can it be related to this final outcome of screen positive or negative. In fact, this model had about 13 million variations in it, parameters, we call them. For comparison, ChatGPT has over 1 trillion more neurons in the brain. So this is a much smaller, simpler, and cheaper model than a large language model that we see today, which is one of the things that we do is like sometimes you don't need a huge hammer for a smaller nail. So then we had to do some kind of, performance metrics on this model. And so we looked at the performance of the model, both on new data that would be seen in the future collected from this health system, as well as we took it to another health system And these metrics here are just kind of accuracy metrics, and they actually could turn out to be pretty good. And the opioid misuse one that we're focusing on here had good performance and accuracy. And in fact, for a screening test, you want to know, well, how many false positives is going to lead to, how many false negatives is going to lead to. And so sensitivity, which is the true negatives and false positives accounted for, is really a good metric for screening. And so the sensitivity on this software was 87%, which is to us acceptable and what's useful. But then we went to like Kelly and the and addiction medicine team and the folks Susan and others on this call, like, hey guys, like, okay, we're seeing there's about 1,000 or there's about 2,000 patients that come into the hospital for admissions across the board, and right now your prevalence is about 1 to 2% have some level of opiate misuse. So if we looked at the number needed to evaluate from this model, it'll lead to about 1.3 or 20, 1.3 cases detected for every one that's truly detected. That's actually true in screening. So that actually comes out to about 26 alerts per 1,000 patients. What I'm getting at here is the workup to detection ratio, the workload burden on you guys, right? We wanted to make sure that we're not going to turn on a software that's going to all of a sudden lead to all these screen positives, and then a lot of them aren't even useful or helpful to you guys. And so this is something called calibration, which is trying to measure the absolute risk to our what we were predicting the risk to be. And so this kind of shows that we were pretty good on our calibration, at least when we did this silently in testing. The other thing we want to be careful of is we don't want the model to kind of be selective in who they identify. And we want to make sure there's no stigma from kind of false positive alerts on individuals that may not have a level of misuse. And so we looked at false positive rates, false negative rates. In this case, I'm just showing a couple demographics, non-Hispanic blacks, non-Hispanic whites, to make sure there weren't major deviations or drifts that would cause concern. And we did this across multiple demographics and even area deprivation indices and things like that, socioeconomic status and stuff like that. Last thing is we want to make sure, is the model actually, these are black box models, but there's ways, we have methods to kind of dig into them and see, okay, what is it actually picking up on? And so we looked at what is this model actually identifying? You can see it's picking up on terms that make sense for what you would expect in someone who may have a substance use disorder. And so that was kind of giving us more content or face validity to this model. So these are all the performance metrics. These are all things that we needed to do before we actually started to think about implementing it. The accuracy, the number of alerts it would lead to, the calibration of the risk it was causing. And so we did that, and then across subgroups, making sure it wasn't leading to identifying individuals across certain socio-demographic groups. And then, there was a model actually picking up on things that made sense to us in terms of like the face validity. So I kind of show all that. Now we're ready to kind of build this model into practice. And that was a huge lift. In fact, it cost us, we had some a grant support on this work, but actually it cost the health system $350,000 just to get this thing to run in our health system because it required some customization and building. And so this picture kind of shows like you guys are working in HealthLink, but this model is actually running in our cloud system in Microsoft Cloud, and it's connecting to the HealthLink as the notes are being fed into it and has to be processed to get all those concepts out and then fed into the model. The model has to make the score, and the score has to be then sent back. And is the score high enough to be a screen positive? All that stuff is being done with our engineers on the back end. So that what happens is you guys get the alert on the front end and within your workflow of HealthLink. It's not going to a separate system. You don't have to go anyplace else. It's popping up as you're kind of doing your documentation and entering the EHR. We did register this on clinicaltrials.gov because we wanted to make this rigorous and show like what we plan to do beforehand and measure kind of does this lead to anything meaningful with consultations. Now, when we registered it, we want to look at two things because when it comes to AI, we're not trying to necessarily prove that it's better than human in this case. We're just trying to prove that it's no worse, but we can provide automation and scale. Because, for instance, that health system in Chicago couldn't afford to keep that staffing. And there was so much turnover, the manual screening is actually completely gone now. And so because from we had this solution, they're at least able to replace it with something like this. But that was the key is like, okay, is this non-inferior to the humans? And is it cost effective? Because we don't want an expensive AI system that we can't afford. The other thing we did is we worked with our implementation scientists to do some of these like rapid plan, do, check, act cycles before we went on to the full implementation, kind of a hybrid effectiveness approach to kind of get at, can we make sure we achieve fidelity? So we worked with your guys' team, the addiction, we came to you guys and asked you questions, and we talked to the end users like the hospitalists and providers and the wards that would be receiving these alerts. A couple things came up. One was, hey, can we get this started in the ED, reduce latency because there's sometimes it's popping up a little bit too late and it's not helpful. The other was, I think it was you, Kelly, that was like, hey, can you get the cows built into this as well? And just like offer the cows at the same time as saying, do you want to consult the addiction medicine service? And that's what the screening tool does, is that it pops up and it makes two recommendations. Hey, this patient may be at risk for an opioid use disorder. Would you like to consult the addiction medicine service to help you make the diagnosis and start treatment potentially? And two, hey, in the meantime, why not just start the cows just in case a patient doesn't experience withdrawal and leave because you're not able to address their needs? And so this is what pops up. So any given provider, you're going to, showing up at work, you open up the chart, and if the patient had screened positive from the model on the back end, this pops up to you on the front end, and this is what you get alerted to do. And so this is for our practitioners, and so they can pick and choose those, and they can choose acknowledge reasons not to do things. And I think this is kind of been iterative. This is an older version. I think Kelly's been involved to kind of help further improve this and kind of figure out how to better use this in workflow. So that's been part of the work. Now, in terms of the implementation study itself, this is what we did. So we worked with actually a health economist, Marlon Munt, Dr. Munt, in the Department of Family Medicine. And we did a kind of a matched pre-post design where we looked at patients that were in the era before we did the AI augmented screening and then patients with the AI augmented screening. We looked across everyone that came through the door in the adult hospitalizations setting. And then of those who went on to receive an addiction medicine consultation, not just the order, but actually a note was dropped, a billing code was received, and then something was done, whether that is starting medication for opioid use disorder or doing harm reduction services or motivational interviewing or referral to treatment. All these things were kind of a composite outcome for us. And so this was the final publication that came out. A couple of findings in the final results was number one, the primary outcome was it non-inferior? It was. It was significant that actually this was no worse than what was being done ad hoc by the providers beforehand, which again, we're not trying to show improvement here. We're just trying to show that this is safe and it's a potentially automation and scalable tool. Now the alerts, this is remember the five rights I was talking about getting it the right person at the right time. It was popping up and alerting everyone that was kind of opening a chart that, maybe a consultant taking care of the patient has nothing, it was, the orthopod who may not be involved in anything related to substance use care that the hospitalist is focusing on. And so that on average, it's led to about 10 BPAs per hospitalization for the screen positive. So but it's kind of continually nudging people. Whether it was the right person or not, it was still nudging, nudging, nudging. Of all the consultations, 13% of them came from this nudge. Of all the BPAs, 22% led to these consultations. Only 3% were actually recorded as being inappropriate, which kind of fit our sensitivity goals here. And then even of the cows, meaning cows was ordered and the nurse was recording a cow score, 27% came from this BPA. Now, I mentioned that it cost about $350,000 to get this thing built up. It was the first time we built an infrastructure like this, so startup costs were there. That's why it was so expensive. But in secondary outcomes, we noticed there was a reduction in 30-day readmissions. Now, this screener, while it was non-inferior, you asked, well, why would that be the case? Well, actually, it was identifying a different type of, it was actually leading to consultations that were happening later in the hospital course because of the nudging. So people that may have not or initially ordered, they were ordering consultations closer to discharge. So maybe the addiction medicine team could help with that kind of discharge planning. And two, it was actually a larger proportion of patients on Medicaid. I think an increasing proportion of patients, of Black patients. And so there was a little bit of distribution shift in who was being identified. We don't know. We can only say these are associations. I can't tell you this is causal. I can't say for sure. These are just things that we notice. We try to account for everything else in the health system. Like the rest of the health system, all the hospitalizations, there was no change in readmission rates. It was only in this subgroup of patients that received the addiction medicine consult with the AI service versus without that we saw this reduction. And we adjusted for demographics, we adjusted for the insurance status, we adjusted for comorbidities, all these things, and it still was there. So what that means is still kind of hypothesis generating. We also this algorithm is being run in another health system. Actually, that same health system, Rush, was also doing this study, but the difference was that they didn't have the in-house expertise to build up the AI version embedded into the EHR. So they actually had, because it was part of a grant, they had research coordinators receive the AI output and then reach out to the team manually through Epic Secure Chat to say, hey, your patient screened positive. Is this someone you'd want to have the addiction medicine service consulted on? Over there, it's called SUIT, Substance Use Intervention Team. Jenna Nicolaides is their director. So your counterpart, Kelly, over there. Again, sensitivity on this tool was good. This shows like there were a lot of patients that were already being identified by the tool that they was already on their consult service. They have a very mature program as well, and their ED providers are pretty well tuned to start it in the ED. About 10% of the cases were actually attributable to this screener that actually led to additional consultations that wouldn't have otherwise happened. And they were running it, we turn on all three services, alcohol, opioid, and non-opioid. So it was actually the full algorithm was being run, but it wasn't fully embedded in the EHR. Now there, while the consultations rate across alcohol, opioid, and non-opioid was 3.8% in a pre-period versus the AI period of 3.4%, while it's only a 0.4% difference, it actually barely crossed the non-inferiority threshold for us, so we couldn't say it was non-inferior, even though meaningfully it's not that much different. And then they actually didn't notice a change in 6-month readmission. Now, again, that's because it wasn't embedded in the HR to change their workflow. It didn't change the behaviors of clinicians. It was just someone kind of contacting individuals based on the algorithm's output. So this is an important point I always make about it's about how you implement, right? This is a totally different implementation. Same AI model, different implementation, different results. But total program cost, it was actually because they were manually screening before until they stopped screening, which happened to be at the same time we started the AI system. It was actually cheaper to run the AI screener than it was to have a human screener. Per human screen, per AI screen, it was actually less expensive. Now they did it a cheaper way because it wasn't built into the HR, so the program costs here are less. But again, it's a different implementation. So you can't do apples to apples comparison. So in conclusion, I just want to, kind of give you these two implementations, same AI model, different, somewhat different results, but these AI-driven workflows can really, in screening programs, can really augment and scale and automate. And I think we showed that in both sites. It really did lead to a kind of cost-effective scaling. Still some evidence on whether that can be associated with good, better outcomes. In our site, we showed that. Other site, it was negligible. But AI-driven automation does ensure that screening does happen, and it does happen at scale, so there's no selection bias. It's, as long as the model's not biased, which I hope I proved to that, it actually can then do a systematic screening for you. And weekends, nights, when human screeners may not be available, this thing is just running. This was a huge team science effort, so big thanks to a handful of you guys on this call who have been part of this work. And our Rush team, our Wisconsin team, a lot of data scientists, data engineers, systems engineers, implementation scientists. So it was a great group effort. The QR code there, actually, we share this model. It's fully open source. So any health system that wants to download the model, and we give some instructions on how to implement the way we implemented it. We actually put this all publicly available for free. So this 13 million model that's trained on EHR data, it's fully de-identified, is actually available to anyone to use for free. Thank you.
Thank you. Are you aware if any new institutions have or are in the process of doing this?
Yeah, UIC, Rush. There are a couple places that are trying to use it for cohort identification because it's a screening tool, but it also could be good for clinical trials. It could be good for epidemiology work, right? It just identifies cases better than ICD codes and anything else that we have. There are other couple places that are using it for like retrospective research stuff.
Anyone on the call have questions, reflections?
Could I ask a quick question? This is Ritu Bhatnagar. I have just joined later, and apologies for that, but just wondering if with this is a really amazing model and knowing already that ChatGPT has evolved itself and over time, do you see any challenges about this model keeping up with new iterations of the AI process?
Yeah, that's a great question. So, right, this is a static model that would need updating if things dramatically change. The CDS committee, we are reviewing this yearly to see if the performance is falling off. So ChatGPT, right, it can look at the notes and tell you this stuff. We actually tested it against multiple types of ChatGPT models, and in some cases it does better. ChatGPT does versus other cases it doesn't. The differences are still not big enough that it's worth the cost. It's expensive to run those huge models. This is a very small model. It's free. It can be run locally, and it's already built into our infrastructure. So I'm waiting for the day where it becomes worthwhile to do. But I think you can get an LLM to do just as well or better. In fact, we have a paper that we did for alcohol use screening where we found that multiple LLMs together off the EHR data did do better than our system here, but not for opioid. So it's still how you implement and kind of put into the workflow. I think that's the issue for us.
Yeah, thank you. And what about like as over time, the language that humans are using to describe the substances changing or the things that it's being screened for that was trained
Yeah.
on, that
Good
changing?
question. Yeah. So the cool thing is because we do that mapping to the medical concept, the National Library of Medicine is updating their dictionary every year. So as new terms show up, they will map those to the same medical concept. So the idea is that hopefully our vocabulary that's currently built into this model will still map to the newer terms because the National Library of Medicine will build those into that vocabulary. Now, that being said, we will want to look at that for sure. And again, these language models are constantly changing, so they're probably better at the vocabulary. But this is a specific medical vocabulary dictionary that's continually updated that these concept IDs map to. So idea is that this would continue to be relevant as the vocabulary changes.
That's really cool. One last thing, I'm sorry to jump in with so many, but one last thing was so since this is the National Library of Medicine and dependent on federal sort of funding and sources and updating and so on, are there concerns about that being a valid? I know we can't, we're
Yeah,
not making political statements. I'm just asking a
to
question in
answer that
terms of that
question.
source. Yeah.
Yeah, but it's a real issue now. Yeah, I don't know. I mean, the National Library of Medicine NLM is what maintains that Metathesaurus and all those ontology dictionaries. And as of now, like the 2024 update is in, it's there, but yeah, I guess it's always a risk, right? So, yeah, I just hope that the federal government continues to invest in this. There hasn't been any notion that they're not. I mean, AI is a kind of a hot topic, and that, at least the current administration supports doing more AI work, and NLM is at the center of that. So I would expect that the funding for this would continue. Hey, Andrew.
Andrew, yeah.
Hey, um, great presentation. I'm curious, for sites that would be looking to implement this, what kind of readiness do they have to have in terms of clinical capabilities for this to be a worthwhile investment from your perspective?
Yeah, that's a great question. That's typically the bottleneck here is they have to be able, so on the back end of this, right? We have this like AI engine that needs to be stood up and built. That this National Library the whole medical concept mapping. It's free, but it takes some technical kind of savviness to get it stood up. So there needs to be data engineers at that health system that are capable of doing this work. I think there are because at least academic centers are this is becoming more commonplace. And then there needs to be that kind of you're familiar with HL7, the interoperability between the EHR and like a cloud system or an external system. So there needs to be some expertise in being able to do that. So, like if they haven't stood it up, it's going to be several hundreds of thousands of dollars. But if they have an existing infrastructure, it should be able to to be built in. So you need someone that has staffing expertise as well as infrastructure to stand a system like this up, which unfortunately is a problem because community hospitals, rural programs, we're still struggling to kind of get the outreach and accessibility there.
Yeah. In terms of like addiction medicine treatment capacity, is that something that factors into that as well? Or
Yeah, that's a great question, right? So screen positive, now what, right? Like if you don't have
yeah,
addiction medicine, so our renewal grant is actually to use AI augmentation to guide, because nowadays, right, I think you guys are advocating like clinicians themselves should become more comfortable diagnosing and treating. So the ER doc doing it or the hospitalist doing it. So we're actually building AI agents to have kind of guide the clinician through these steps and make them comfortable and familiar and able to actually initiate treatment without having an addiction medicine consultant in-house.